know that the first 2 days I know were already available as YouTube videos. If you want, I can ask Priya to send it to you.
Yeah, they are available actually. I think
Okay.
Vaishali, madam had sent a link also first 2 days.
Yes, ma'am. We are live. You can start.
Good evening, everyone. Welcome to day 5 of the virtual series conducted by Divas on women's health. So normally when we start a series like this, we wait for the last day and everything to end successfully. And I have to tell you, the first 4 days have been so incredibly wonderful. We have had amazing feedback thanks to the brilliant keynote speakers and the Meet the Professor panelists and the moderators and the takeaway and question answer coordinators who have done such a brilliant job of making this so seamlessly wonderful. Today's keynote speaker is a dear friend and an amazing woman from Singapore. We're very proud that she's from India. So Professor Manju Chandran sent me an email saying that she said, I fervently wish I had the same passionate, brilliant, and yet humble group of colleagues that you have. And I must tell you that I couldn't have said it better. I must thank and give all of this to the wonderful colleagues who have made this program so amazing. Thank you so much for being part of the team and doing this for us. So today's program is on two important topics in women's health and intertwined. It's osteoporosis and bone health and menopause. And we know that women are at greater risk for osteoporosis and particularly postmenopausal. And it just seemed right to bring these two topics together. And the keynote speaker, next slide please, is going to be Professor Manju Chandran. And don't get fooled by that beautiful face. This is an amazingly brilliant woman who has done so much. And then when I show you her bio, you will see how much work she's done in the space of bone health. Next slide. So this doesn't do justice to her. I'm going to go to the. I think we added 2 new slides to her.
Oh my God.
Bio. Next slide, please. No, I don't think we have that yet. Can you go to the previous slide? I'll do this and then come back to the others. So, Senior Consultant and Director at the Osteoporosis and Bone Metabolism Unit, Department of Endocrinology, Singapore General Hospital. Chairperson of the Asia Pacific Consortium on Osteoporosis. Member of the board of the International Osteoporosis Foundation. And I have to tell you, she's the first woman on the board, first woman from Asia on the board. Council member, Committee of Scientific Advisors, International Osteoporosis Foundation, Deputy Chairperson, Asia Pacific, South Africa, Regional Advisory Council of the International Osteoporosis Foundation, and Vice Chairperson of the Asia Pacific Panel of the International Society of Clinical Densitometry. Professor Manju Chandran came as our faculty a few years ago when Chennai conducted the Indian Society of Bone and Mineral Research's annual conference and was such an instant hit. And every time we conduct a conference, everybody wants me to invite her. So thank you, Manju, for being part of our program today. Next slide, please. Next slide, please. So the other 2 professors who will be joining Manju Chandran today, Professor Manoj Chadha and Dr. Jayashree Gajraj, my very, very dear friend from childhood. Next slide, please. So Jayashree Gajraj is a senior consultant OBGYN from Chennai. She is at the Apollo Specialities Hospital and has her own women's health center called Mangai, which is a women's health exclusive. She's a past president of the OBGYN Society of South India and past chair of the RCOG and founder, secretary, and president of the Chennai Menopause Society, which is why I think she'd be absolutely the right person to be here today, and president of the ATN RCOG, And no surprise, she got the Best Doctor Award from our MGR Medical University. Again, more than anything, Jayashree and I know each other for a very long time, and someone who is, an incredibly academically oriented and is part of everything that we do, and has been part of a lot of our clinical trials, and absolutely, adore what she brings to clinical care. Next slide, please. And then our friend, Professor Manoj Chandran. Manoj is from the St. GS Medical College, consultant endocrinologist at the Hinduja Hospital and his own Hope and Care Center, trained at the University of Ulm, Germany in use of artificial pancreas. Immediate past president of the Indian Society for Bone and Mineral Research, and actually my go-to guy for anything relating to ISBMR. Pick up the phone and talk to him. And also the past president of the Endocrine Society of India, has been conferred the fellowship of the Indian College of Physicians and the Royal College of Physicians of Ireland. A dear friend, and I'm so grateful that he's part of this program today. Thank you, Manoj. Next slide, please. So the moderators for the session today are three amazing people again. My colleague, Dr. Bhuma Srinivasan, who's and Dr. Vaishali Deshmukh and Krishnan Swaminathan. Next slide, please. Dr. Bhuma Srinivasan is an American board-certified endocrinologist and diabetologist, consultant in endocrinology at Vijaya Hospitals, Chennai, graduated from the Madras Medical College, like I said, certified by the American Board of Endocrinology, Metabolism, and Diabetes, and did her postdoctoral research in osteoporosis at the Mayo Clinic in Rochester. Has many publications and has been part of all our osteoporosis clinical trials. And I don't think we would have done and gotten the kind of recognition for our osteoporosis trials without Bhuma. Thank you so much. Next slide, please. So Swami, Dr. Krishnan Swaminathan, is an endocrinologist from Coimbatore, also from the Madras Medical College, and trained in the UK, including in Cambridge and Scotland, has an MRCP and an FRCP from the Royal College of Physicians. Currently, he's, believe it or not, a student at IIT Madras doing a part-time PhD on novel pathophysiological aspects of diabetes in rural India, and is doing tremendous work in this space, especially with all the environmental disruptors that we are hearing about. And he's also the founding trustee of Idayangal, and this is for type 1 diabetes. I have personally seen the work that they are doing, providing, including pumps for the kids from the low resource, low resource settings. So I'm so grateful that Swami is part of this program. Everyone loves him because of the way he delivers his talks. Next slide, please. Dr. Vaishali Deshmukh, again, someone I've known for a long time, first female endocrinologist in the city of Pune, and assistant professor in endocrinology at Sassoon General Hospital and BJMC Pune. And she's the head of endocrinology at the Dinanath Mangeshkar Hospital, Pune, heads the Deshmukh Clinic and Research Center, consultant endocrinologist at Ruby Hall Clinic, has been a principal investigator of many trials, and has many national, international publications, and the director of the Wellness of Women Clinic, and the secretary of Sphere, and has been doing really some wonderful path-breaking things, especially in the realm of women and diabetes. Active person in the Women in Endocrinology group. I really want to thank Vaishali for being part of this program today. Next slide, please. So Vidya, Dr. Vidya is also from Coimbatore, also from the Kovai Medical Center. I'm sorry, I think I messed up your slide a little bit when I transferred it. Trained in diabetes and endocrinology, and from the UK, worked as a consultant there for many years. One of the brightest, spirited young persons that I have met. I tried to get her to come to Chennai, but she's still keen on staying in Coimbatore. Really love her spirit and the way she's doing medicine in Coimbatore. Thank you, Vidya, for being here. She will do the audience Q&A. Next slide. And this is our own Dr. Mangleshwari, who works with me at DHS. Mangleshwari is a family physician with very special interest in stress disorders in women. So I think that's a special strength and gift for us, that she's able to counsel a lot of our patients. And I thank Manglesh for doing the takeaways today. Thank you so much. This brings us to the keynote address. Next slide, please. So now, can you share your slides, Manju?
Sure.
Yeah.
Oh, you have to stop sharing, Usha.
No, they'll do it. This is something that's being done in Ahmedabad. So they'll do it from the center. So can you, she's going to share the slides now.
Yes, ma'am. Yes, ma'am.
Yeah.
Okay, 1 second.
Awesome. Yeah, it's all set.
Cool.
Yeah.
Ready?
Yes.
Okay. Well, good evening, everybody, and thank you so much, Usha. It's always an absolute pleasure to speak at a congress organized by you. You know that now. And Usha, you also know that I like doing catchy titles. So management strategies for postmenopausal osteoporosis from Mantra to monoclonal antibodies and matters in between. So because all I have is 20 minutes or so, I plan to just whisk you through the current management strategies in osteoporosis. Where are we right now? Where are we going? And how can we get there? So osteoporosis has been around with us for a long time. And possibly Manthara or Kuni from the Ramayana, you know, the evil maidservant of Kaikeyi, is probably the first described case of osteoporosis, especially of thoracic vertebral fractures. But there have been other instances of osteoporosis around, including Egyptian mummies who have been found to have osteoporosis, as well as this Austrian Bronze Age skeleton, which was found in a farm field, this skeleton belonged to actually possibly a 45-year-old woman. Which brings us to this critically astute observation by David Marsh, who has described individuals as having an osteoporotic career. Now, when that career begins could be different for different women. It could be at the age of 50, a woman having a forearm fracture. At the age of 60, she could have a pelvis or a humerus fracture. At the age of 80, she could have a hip fracture. But what we have known since the 1980s is that half of individuals who have a hip fracture have suffered another fracture in the months or years preceding the hip fracture. Put it simply, half of people who break their hip have told us that they're coming. The thing is, we need to be listening to make changes. But unfortunately, we're not. I'll just leave this up for a second so you can read it. We are not doing our job. We believe patients will automatically be taken care of by someone else. And that's a fundamental flaw of osteoporosis management, and that which has resulted in the underdiagnosis and undertreatment of osteoporosis. Once a patient falls into this black hole of osteoporosis and fragility fractures, it's not sure who is going to help that patient. There's absolutely no communication between the multiple specialties involved in osteoporosis care. There's no communication between tertiary and primary care. No one is being held accountable. You know, nobody did what anybody could have done. That's unfortunately the sad situation right now in osteoporosis. But now that I've painted a picture of doom and gloom, let's see how we can kind of take steps to rectify this problem. So let's start with screening for osteoporosis. Now, this was actually mentioned to me by a very witty Japanese colleague of mine who told me that wouldn't it be great if airport security cameras could be used for screening for osteoporosis? I found it pretty funny, to be honest. So if we were to talk about screening for osteoporosis, what can we use? There are several simple questionnaires have been designed to help target high-risk women for BMD measurements. And this is to avoid the cost of measuring women at low risk. And you know, these high-risk women are postmenopausal women, because osteoporosis risk is high in postmenopausal women because that's a hypogonadal state with a rapid rate of BMD loss. And the average age of menopause varies in different nationalities and different ethnicities, but probably between the ages of 42 to 56 years old. And I believe that in India, the average age of menopause a little bit earlier probably is about 46 or so. So there are several of these screening tools which can be used to assess the risk for osteoporosis, to see whether the patient has a densitometric diagnosis of osteoporosis. There is an osteoporosis self-assessment tool for Asians. There is a fracture risk assessment tool, which was primarily, FRAX was primarily a fracture risk assessment tool, but can also be used as a screening tool for osteoporosis. I'll talk about that very briefly. In the simple calculated osteoporosis risk estimation, the score, which I understand again in India, a couple of studies have looked at the validity and the value of a score in assessing the risk of osteoporosis. And there are several other risk assessment tools. And we have actually looked at it. We have compared the OSTER against the fracture risk assessment tool FRAX, which, like I said, is a fracture risk assessment tool primarily, but can be used to identify densitometric diagnosis of osteoporosis too. And this was among Singaporean women. And what we found was that both FRAX as well as osteoporosis self-assessment tool for Asians, which is weight minus age times 0.2, both these had comparable accuracies in picking up a densitometric diagnosis of osteoporosis. And what we found was that a FRAX major osteoporotic fracture probability of about 3.7 and a hip fracture probability of 0.6 and an OST index of less than minus 1.2 had pretty reasonable sensitivities and specificities to pick up a densitometric diagnosis of osteoporosis. So these screening tools can be used to pick up a diagnosis of osteoporosis. But what about fracture risk assessment? And again, there are lots of fracture risk assessment tools available. And so I don't know whether the sages of yore could have predicted whether Manthara would develop all those vertebral fractures. But right now, currently, there are several fracture risk assessment tools available across the world, including FRAX, Q fracture, Garvin, and you can read through these whole host of fracture risk assessment tools available. But FRAX is probably the only one which not only was it developed internationally in multiple cohorts, it's also the only one which probably has been validated in cohorts, in multiple cohorts outside of the cohorts in which it was developed. And most people know FRAX, and India also is a FRAX model. Now, India is in a unique situation in that it uses a Singaporean Indian FRAX model as a proxy. But India also has a FRAX model. So we move from screening of osteoporosis, we have moved on to fracture risk assessment and the diagnosis of osteoporosis. So even when we're talking about diagnosis of osteoporosis, we have come a long way. From the time when DEXA, dual energy X-ray absorptiometry, was just used to measure BMD, we have come a long way. Now we have, using DEXA itself, we can do finite element analysis. We have the trabecular bone score, which is textural analysis. We can measure indices such as the hip structural analysis, HSA, cross-sectional modulus of inertia. You can use VFA, vertebral fracture assessment, which is a part of, as a part of DEXA scanning to identify silent vertebral fractures. You can do body composition analysis using DEXA scan. And recently there are all these fancy gizmos, such as 3D reconstruction of proximal femur from 2D DEXA, etc. So DEXA has also come a long way from the time that osteoporosis was first diagnosed using DEXA. So then we move on to secondary osteoporosis. What about secondary osteoporosis? Where are we right now as far as this particular situation is concerned? Now, very interestingly, we know that there are several medical conditions, there are several medications associated with bone loss. And what we found, again, was that almost up to about 45% of what we can think of just, this is just garden variety postmenopausal osteoporosis, actually does have a secondary contributor. And I would like to use the word secondary contributor rather than a secondary cause. So 45% of simple garden variety postmenopausal osteoporosis might have a secondary contributor. And it behoves us to find out what are the common conditions prevalent in your own country, in each region, so that you don't have to screen for all the secondary causes, contributors of osteoporosis, but you could probably do the ones which are more prevalent. So secondary osteoporosis definitely is something which has to be ruled out before you even start talking about treatment. And we move on to treatment. Who do we treat? So here we're walking a very thin line. You want to facilitate treatment of patients at high risk of fracture, but at the same time, you want to minimize overzealous treatment of those at lower indeterminate risk. So therapeutic strategies that rely solely on BMD testing may miss several patients at risk of fracture. And so clinical risk factors that operate independent of BMD should be considered. And that is where, again, a fracture risk assessment tool such as FRAX comes into play. So when you talk about intervention thresholds, so you've screened, you have identified fracture risk, you have diagnosed osteoporosis, you have ruled out secondary contributors. Now you're talking about intervention thresholds. When we come to intervention thresholds is where you can yourself see. This is actually a 5 IQ analysis which we did, findings from osteoporosis guidelines from 18 countries. Asia Pacific Consortium on Osteoporosis embarked on this project, and you can see that there are multiple indications for treatment in the different guidelines across the Asia Pacific region. Definitely a fragility fracture, history of a fragility fracture appears to be an indication for treatment. But what kind of fracture? Some guidelines say it's a hip fracture, some guidelines say vertebral fracture. FRAX, again, we'll talk about FRAX intervention thresholds in a second. BMD DEXA T-score was indicated in a few of guidelines. So intervention thresholds vary, and again, it has to be probably country specific and also based on the evidence that we have whether medications are effective in treating osteoporosis and preventing fractures. So FRAX, I'll stop to talk a little bit on FRAX, because FRAX, like I said, is probably the only fracture risk assessment tool that has been developed in an international population with multiple cohorts, and it has been validated in multiple cohorts outside the original cohort in which it was developed. And FRAX originally was developed by the WHO in collaboration with the University of Sheffield, with a working group at the University of Sheffield. And FRAX was meant to be just an engine of risk. It was meant to be a platform which would help enable decision-making in osteoporosis treatment. But, I sometimes think that is actually an engine of contention, because it has led to so many polarizing views, emotional and polarizing views amongst people. People just take FRAX and think of it as God's spell, and forgetting the fact that this is just a platform. It has got lots of loopholes. People get so emotional about it, about what intervention thresholds to use, what kind of intervention threshold should we be using, etc. And as you can see, if you were to talk of FRAX-based intervention thresholds, you can have fixed thresholds applied to men and women regardless of age. You could have age-dependent thresholds, and you can have hybrid thresholds, which is a combination, obviously, of the fixed and the age-dependent thresholds. Now, whether the ideal treatment threshold should be a fixed one, age-dependent, or a hybrid of the two is unclear. But what is certain is that everybody wants to be a part of FRAX. I mean, when we did the survey a few years ago in the Asia Pacific region, again found that a significant proportion of physicians across the Asia Pacific said that they would want FRAX to be developed in their country, and they would like to treat based on FRAX intervention thresholds. And I know personally the polarizing and the emotional opinions about FRAX, because we have looked at developing intervention thresholds based on FRAX in Singapore. We just recently published cost effectiveness of FRAX-based intervention thresholds in Singapore. And honestly, really, this has led to so much of political drama and, political drama and arguments between a lot of us so-called osteoporotians, because we still can't get together and decide, hey, this is the intervention threshold that we should be considering for use in treatment of postmenopausal osteoporosis in women. But it's a fantastic platform. It has got lots of loopholes, but it's a fantastic platform. Before FRAX, we really did not have any way of putting together these clinical risk factors in addition to BMD to identify fracture risk. So from there, we move on to let's say we do come to a consensus and we do decide who to treat. Then the next question is obviously, how do you prevent osteoporosis? How do you prevent osteoporotic fragility fractures? And what medications do you treat patients with? And I always like to kind of say that this is this picture I snitched from the Straits Times in Singapore, which I consider the New England Journal of Medicine in the East. And all of you know that exercise is important for building up bone health. Which brings us to the next question, the next controversy in osteoporosis and current day osteoporosis management, way remote from the times of Manthara. Does supplemental calcium and or vitamin D lead to reduced fracture risk, and are they associated with other side effects? Now, this is again another very, very controversial topic. We can talk about it in the Q&A session if we have time. So the jury is still out there, as what it appears to be is that the benefits of calcium are intermingled with that of vitamin D. It seems to have an effect on about 10 to 12% decrease in fractures, especially hip fractures. The combination of calcium and vitamin D, it seems to work better. Calcium supplementation seems to work better in people with lower baseline intake of calcium. It seems to work better if the vitamin D level is low, less than about 10 nanograms per ml, which I think most of us Indians have that. And it seems to work better in older institutionalized individuals. And of course, there is this concern about calcium and cardiovascular risk, which again, there's lots of controversy surrounding it. So I will not go into it in detail, but just to suffice to say that this in current day osteoporosis management, this is another controversial area. So when we talk about advances in osteoporosis medications, again, we have come a long ways from the time of the 1980s when estrogen was used for the prevention and treatment of postmenopausal osteoporosis. We have gone through calcitonin, we have gone through the tried and trusty bisphosphonates, the selective estrogen receptor modulator raloxifene. In 2002, teriparatide, the first anabolic agent for osteoporosis, was approved. Then some agents kind of fell by the wayside, like strontium. Denosumab was launched in 2010, and a couple of years ago, abaloparatide, which is a PTHRP analog, and then just last year, romosozumab, which is a sclerostin inhibitor, was launched, not available in India as well as in Singapore yet. So I'm not going to belabor the point about all the different kinds of anti-osteoporosis medications available. Of course, you have hormone replacement therapy, which has shown excellent fracture risk reduction, vertebral, non-vertebral, as well as hip in general population. SERMs, raloxifene, again, which has shown very good vertebral fracture risk reduction, but has not shown any non-vertebral fractures reduction. The bisphosphonates are tried and trusty old steeds, which have been around. And in fact, I'm not sure whether any one of you were aware that last year, 2019, was the 50th birthday of bisphosphonate use in postmenopausal osteoporosis. So it was celebrated with quite a bit bang by people who are into those kind of things. And you have denosumab, which through the FREEDOM trial, we have shown excellent vertebral, non-vertebral, and hip fracture risk reduction. But several unsettled issues remain with bisphosphonates as well as denosumab. How long do you treat? What are the effects after discontinuation of therapy? What's this concept of drug holiday, which is unique to bisphosphonates? Side effects still kind of plague us. We still worry about it. I get eaten alive whenever I'm talking about this at conferences. Side effects including atypical fractures and osteonecrosis of jaw. And then now we also are faced with this phenomenon, the rebound risk of vertebral fractures after denosumab discontinuation. So that's still an unsettled issue. But the important thing is to keep things in perspective. When you're talking about the risks versus benefits of these anti-resorptive agents, especially bisphosphonates, the risk-benefit ratio clearly favors bisphosphonate treatment in women at high risk of fracture. And what I tell my patients is that for every about 100 hip fractures per 10,000 high-risk patients that are averted by treatment, you can expect about 3 subtrochanteric fractures. So the risk can be anywhere from 1 in 100,000 to 5 in 10,000. And obviously the risk increases as with prolonged duration of treatment, but still by and large, risk-benefit ratio clearly favors bisphosphonate treatment in women at high risk of fracture. So our anabolic therapies, the holy grail that we boneheads have been searching for all our lives, And the current available anabolic agents, which are the PTH and the PTHRP analogs, you have teriparatide, which has shown significant vertebral fracture, as well as pretty good non-vertebral fracture risk reduction. And obviously, we could not really find a hip fracture reduction because the study had to be terminated early due to the toxicology study in rodents, which showed osteosarcoma risk. And abaloparatide, which is a PTHRP analog, I'm not sure whether it's available in India yet, but again has shown good vertebral fracture and non-vertebral fracture risk reduction. So when we talk about advances in osteoporosis treatment, you have to talk about developments of new molecules and targets. And this development of new molecules and targets signaled the move away from serendipitous pharmacology. Bisphosphonates were used as pipe cleaners in the past. I mean, so we kind of stumbled upon bisphosphonate it could be used for postmenopausal osteoporosis treatment. So we're moving away from kind of a serendipitous pharmacology to more targeted therapy. And the study of certain high BMD disorders, such as sclerostosis, which is due to decreased expression of the SOS gene, and its milder form, which is the Van Buchem disease, which is due to deletion of a SOS-specific regulatory element, which is more downstream, has led to kind of incredible advances in the development of anabolic therapies. And study of the sclerostin gene, as well as other things, led to the discovery of sclerostin, which is an inhibitor of bone formation. So romosozumab is a monoclonal antibody which binds to sclerostin and it increases bone formation. And the pivotal study with romosozumab was a FRAME, or the fracture study in postmenopausal women with osteoporosis, in which postmenopausal women with osteoporosis were assigned romosozumab, which is a sclerostin monoclonal antibody, which is given as a 210 milligram subcutaneous injection once a month, or placebo, followed by 1 year of open label denosumab. And this kind of laid the foundation for something which we call the foundation effect, in which we are moving away from the traditional kind of plodding along. First, let's start with an anti-resorptive, then move on to an anabolic agent, which we realize, in fact, can be harmful at times, to, in fact, rebuilding bone with the first 1 year of an anabolic agent, in this case with romosozumab, building up the foundation and then maintaining that foundation with an anti-resorptive, in this case with denosumab afterwards. So this is the foundation effect, which is really now revolutionized, I should say, osteoporosis treatment, the concept of osteoporosis treatment. And with that, I talk about patients at very high fracture risk. So I earlier told you about the osteoporotic career, in which women with previous history of fractures are at high risk for fracture. And the highest risk of a second fracture occurs within the first 2 years of the index fracture. And in fact, 61% of fractures after hip fracture will occur within the first 2 years, and 42% of fractures after vertebral fracture will occur in the first 2 years. So those first 2 years after an index fracture, the very critical ones, and this seems to be an age-dependent phenomenon, but those first 2 years seem to be extremely critical. And this is where probably you should be, instead of plodding along with an anti-resorptive, then moving on to an anabolic agent, possibly we should be considering use of an anabolic agent, especially in these people at very high fracture risk. And thankfully, the recognition that fractures beget fractures has led to the development of multiple fracture liaison services across the globe. And we have been very fortunate to have, build up our own fracture liaison service called Optimal in Singapore. And this is really, again, hopefully will be a remarkable advancement, and hopefully will lead to a reduction in the number of osteoporotic fragile fractures that the world suffers from. So in conclusion, currently, we have good ways to predict who might fracture by combining measurements of bone mass with assessment of clinical risk factors. However, I'm not afraid to say that the emperor does not have any clothes. And so I'm saying that we have ways only to strengthen weak bones enough to prevent a fraction of the fragility fractures happening worldwide. Current therapies are designed for broad epidemiologically defined groups and result in variable effectiveness. So the idea of personalized precision medicine in the osteoporosis world has no real meaning yet. However, we have come a long way from Manthara's time, And now we have, even artificial intelligence. We have moved from monoclonal antibodies in the treatment of osteoporosis. Now we have starting to employ artificial intelligence in osteoporosis. We're employing the use of machine learning models to diagnose osteoporotic fractures, to identify risk groups for osteoporosis, etc. So though I have painted a picture of doom and gloom of the osteoporosis management curve over the last few years, it was a rapid rise. It was wonderful in the initial years with DEXA being introduced, approval of bisphosphonates, approval of more drugs, screening tools, FRAX. But then we started on this downward slide when people started getting concerned about all these side effects. People started taking people off of anti-osteoporosis medications. The calcium side effects came up. Drug holidays, are they good? Are they bad? Competing guidelines, like I said, 18 guidelines across the Asia Pacific region. But even though I painted a picture of doom and gloom, I would like to say that there is light at the end of the tunnel. We've come a long way from Manthara. We moved from different kinds of screening tools to advances in densitometry. We have identified ways to identify people at risk for fractures. We have come up with multiple new medications and now artificial intelligence in the use of osteoporosis. And so stay tuned, folks. There is light at the end of the tunnel. And I would just like to kind of just briefly bring up the Asia Pacific Consortium on Osteoporosis. Please do go visit the website. It's comprised as of now of more than 40 osteoporosis experts, osteoporosians from more than 19 countries across the Asia Pacific region. And we have our very own dear Professor Manoj Chandran also in there, and Professor Sanjay Badada from Chandigarh is also in the Asia Pacific Consortium on Osteoporosis. So for that, I really thank you for your undivided attention. You didn't have a choice, really, I guess. Thank you very much.
Thank you so much, Manju. That was incredible. I think there was a lovely trip through what's been happening in the osteoporosis field and what we are challenged with. So thank you so much. So we move straight to meet the professor. Boma, you can take over.
Yes. I would like to take this opportunity to thank Professor Chandran for giving such a nice talk, looking at the various diagnostic methods, assessment tools, and the various treatment options that we have today. Thank you. Now I'm going to welcome our panelists, Professor Chandran, Professor Manoj Chandran, Dr. Jayashree Gajraj. Now the first question is to Dr. Jayashree Gajraj. This is about the menopausal age in our country. As it was alluded to, the Pan-India survey showed, the Indian Menopausal Society showed that the menopausal age is 46.2 years in our population compared to 51 in the Western counterparts. And there are various studies that show ranges from 42 to 49. Now, is it changing in our country? Are younger women experiencing menopausal symptoms, or is it going up? What is the trend now? And is there an urban and rural divide? And what are the factors that are contributing to this younger age of menopause in our population? Dr. Jayashree.
To begin with, thank you, Usha, and the entire team. It's been lovely to be here. I only logged in yesterday, and listening to Professor Chandran today was a real treat. Thank you for having me on the faculty. Talking about menopausal age, I think traditionally we've all grown up with this 50.8 years as the magical figure for menopause. And then slowly we realized that in India, it is definitely different. Women were attaining menopause at a younger age group. And again, in earlier days, some of us chose to ignore it. We thought, okay, that may not be right. Maybe we are just seeing a few people. But as you quite rightly said, Dr. Meeta did this huge study, pan-India, and she came up with this figure of 46.2. And the FOGSI also has said it's about 47.5 years. So we are dealing with a younger age group, which means the responsibility on us as caregivers, we have to shift our care a little younger. We don't focus on 50 as the age of menopause, which alerts us to many factors that we have to start thinking of even from the early 40s in a woman. And with regard to the rural and urban divide, I probably may not be able to give you much information, but menopause itself is a recognized entity more in the urban areas rather than in the rural areas. So that way, women seeking help will definitely be more in the cities, in the metros, rather than in the villages. But every woman, I'm sure, is undergoing all these changes, whether it's in a village or whether it is in a city. And the physical activity of women in the rural areas is much more. And their commitment to what they do every day, everything, their demands on life and expectations are different. So probably we don't see this much of a menopausal change in the rural areas. And whether, yeah, yes, Uma.
Yes, go ahead, Praktish.
So we definitely are seeing more women coming forward and asking for help nowadays. Right from the 90s, I would say this awareness was there. And then we all know that this WHI came and then there was a big slump. People did not want any help at all. And again, people realized that help with menopausal symptoms was not necessarily menopausal hormone treatment, and there was much more to it. So again, we've come back full circle. People are coming to us now with menopausal symptoms, seeking some kind of help.
And when it comes to seeking help, do you see any particular characteristics? Is it economics? Is it social factors? Is it literacy? Is it family factors? Is there any specific reason why, or is it the severity of symptoms that brings them to you?
See, actually, talking about the socioeconomic or the cultural background, way back in the early 80s, I actually assessed about 200 perimenopausal women. I'm talking about when I was doing my diploma several years ago. And this was all a population who were attending a government hospital. The incidence of vasomotor symptoms was significant in these women. So most of the time, it's just that these were leading questions. A questionnaire was given, and we were actually doing the so-called pycnotic index those days to try and assess their estrogen status, etc., which I know nowadays is an outdated way of looking at it. But it was something eye-opener for us. So yes, it does exist across the social and the cultural background. But in our practice, we find women who are more affluent, women who know that even if there is something being offered, they can afford to take it, are the women who are actually coming forward on their own. But over the years, we have developed this practice of asking women leading questions, ask them whether they have vasomotor symptoms, ask them if they have any symptoms relating to vaginal atrophy or urological symptoms. So that way, yes, we are asking leading questions. I think we have changed our attitude towards them as well.
Okay. You mentioned vasomotor symptoms and vaginal atrophy. Do they also come to you for sleep disturbance? And many times people say, I've lost my memory, or I'm unable to concentrate, things like that. These are the usual, they think when menopause came, everything is really falling apart.
Yeah, I think that's very true. And I'm sure all of us can relate to that as well, without doubt. They do. I mean, one is, of course, the mood changes are one of the first things that we see. The menstrual irregularities, etc., get taken care of. But the mood changes, that's something we see very often. And then, of course, you have these women with this occasional hot flush who takes them some time to realize that this may be due to the impending menopause. So by the time they come to you, they've had it already for a few months or even a year or a little more. So I think recognition, if we start creating awareness, these women may actually come forward much earlier. So it takes time to realize that this is actually a symptom of the impending menopause.
Okay. And I think when they come, it's probably pretty straightforward. It's postmenopausal symptoms, menopausal symptoms. But do you do any assessment relating to thyroid, or do you do an FSH to establish it as menopause, or do you check a prolactin because of the periods? Do you do any assessment at all?
If they come with an abnormal uterine bleeding, then the diagnostic algorithm goes along the AUB pathway. But otherwise, if they just come to us, there is really no need. We do not routinely do FSH or anything because, she could have a borderline or even a normal FSH and still have the symptoms. At the end of the day, we have to relieve their symptoms and not reach the FSH. So we do not do anything to prove that she is menopausal or approaching menopause before we start treating.
Okay. Now, every patient would want the answer from you as they are going through this. How long do they have to live with this?
See, I think we all tell our patients that hot flushes last for 2 to 3 years. But let me tell you, I personally had to deal with it for almost 10 years. Okay, I don't mind accepting this, but it was difficult. So I do not blatantly, openly tell my women it's only going to last for 2 to 3 years. I have that little reservation when I tell them. So we just have to take them along. I think they come back to you for frequent visits. Every time they come, you counsel them. And if they are still having it, you just encourage them and take them along. I think that is the way to approach, rather than saying, don't worry, in 2 years, it's all going to vanish.
Thank you. And Professor Chandran, do you have anything to add?
No, I'm actually quite curious, Dr. Jayashree. I mean, because the Asian mentality is more kind of an acceptance of menopause as a natural fact of life, as opposed to probably in the Caucasians who are really kind of aware of all this. And you said that there wasn't much difference these days amongst the rural versus urban population, your patients that you treat, there isn't a difference now? Is that what you were saying?
No. I think rural, they may still have it, but they may not come forward.
Exactly, yeah. And they consider it as like a way of life. This is a fact of life. You just have to accept it and move on with it. Is that what's probably making them not come forward?
See, their priorities are different, Manju. Their priorities are totally different.
Different, exactly.
They are working for their daily bread. They have got other things to concentrate.
Exactly.
So an occasional hot flush is not going to disturb them. Whereas a woman who is earning whatever, amount of money per annum, she thinks she wants relief from it.
Exactly, yeah. And I would think that there's also an ethnic kind of probably a difference too between Asians and Caucasians. I personally, I mean, haven't delved into it much, but I would assume that there is a ethnic difference also in the way women perceive this.
See, they look at the advantages of a menopause, because once they stop having their periods, they can go to the temple anytime.
Freedom, exactly.
They can join any cultural function. They don't have to sit around. There are still households where the 3 or 5 days, they're totally not even allowed into the house.
Okay.
So they look at it as a freedom. So, I can put up with the occasional hot flush. So what?
Very interesting. Yes, exactly.
And also a joint family, people, when they live in joint families, there's a lot of, that kind of support. I went through this is going to last this long, you too will be okay. So I think a lot of menopausal symptoms is, especially I can tell you personally, what I felt was there was a period when I was just a little bit more fearful of a lot of things, a lot of diffidence, and it went away. So if somebody told me, this is just part of this and it'll go away after some time, it was very reassuring. So it's all, when women live alone in those, and not much of support system, these are scary symptoms.
Yeah.
And Dr. Manoj, any comments?
I just wanted to add a little away from what we've been discussing. Is traditionally we've been taught that with aging you lose about 1% of your bone mass every year, but 2 years perimenopausal and 2 years postmenopausal, the rate of bone loss may be anything between 3 and 5%.
Correct.
Exactly.
So this is the real time if you want to intervene. This is the time to hit.
Yes. Okay. So I'll move on to the next question to Professor Chandran. 56-year-old female, 10 years postmenopausal, BMI of 26, has a fall and sustains a Achilles fracture. She has no known medical problems except lactose intolerance, for which she takes soy milk. BMD shows a spine T-score of -2.6 and a Z-score of -2.8, hip T-score of -2.1 and Z 2.4. How should we approach this young woman? Is 10 years of estrogen deficiency good enough to describe the fracture risk? Or do we go ahead and do work her up for secondary causes of osteoporosis?
Okay. Well, I often joke that these kind of challenging case discussions at conferences are like vivas for senior doctors. It's kind of a trial by fire where you're like sweating bullets and hoping that you don't open your mouth and make some ginormous mistake. But so this case, so she's this relatively young. I would not call her young, but relatively young. We are all getting there. A relatively young woman. She's a bit on the overweight side. She's got a BMI of 26, and a trivial fall has resulted in quite a bad fracture, Colles fracture. And this is actually just for probably the younger fellows' information. This is the typical fracture which was most often seen in younger patients, because they still have the protective mechanisms intact. And so when they fall with their hands outstretched, and that's why they sustain Colles fractures. Whereas an older woman, protective mechanisms may be lost, and so she's more likely to fall to the side and thus have a hip fracture. So as I brought up in my presentation, but almost close to, and this number could vary between different ethnicities, obviously in different countries, but we found that about 45% of what we thought is garden variety postmenopausal osteoporosis had a secondary contributor, and this could be picked up only by lab testing. So in this lady who's osteoporotic by DEXA definition, and she's also has had a Colles fracture, because she's relatively young, definitely I would like to kind of make sure that she doesn't have any secondary contributors to osteoporosis before deciding on whether to treat her and what to treat her with. Now, interestingly, just to kind of, I can't, can my pointer be seen? Or it's not possible, right? So this lady, people may say, oh, Z-score of minus 2.4. Is that a good indication? Does that kind of rule in or rule out a secondary contributor to a secondary cause of osteoporosis? Now, again, what we as well as others have shown is that there is no particular Z-score threshold which can rule in or rule out secondary osteoporosis. And we use various diagnostic thresholds, -1, minus 1.5, -2, and the ROC curves actually showed very poor predictive capability. But in general, a lower Z-score would indicate that there is some other condition other than just menopause, other than just aging, contributing to this lady's bone loss, and therefore it should be looked into. And what tests would I order? Again, like I emphasized, it behoves upon you to kind of figure out what the most common prevalent conditions in your country are, so that we don't go searching for the 101 different secondary contributors to osteoporosis that we know of. I mean, of course, you have to get a very detailed history from her. You said she doesn't have any other medical problems, but maybe I don't know whether she's on any other medications, whether she's taking some traditional kind of medications, which may also sometimes be associated with bone loss. Does she have any other medical conditions? Get a family, is there a strong family history of fracture in her? And then I would do certain lab tests, and the basic, probably a must, at least that's what I tell my fellows are, would include thyroid function tests. I would order serum creatinine for sure, and depending on whether multiple myeloma, I mean, how common it is in your population or not, I'm not sure, but I mean, I definitely would insist on just a full blood count, a serum creatinine, and an ESR. If the ESR is high, patient has an elevated serum creatinine without any other cause for that elevated serum creatinine, and if she's anemic, then I would start thinking of multiple myeloma, though obviously multiple myeloma doesn't usually press on the Colles fracture, but again, that has to be kept in mind. I would probably order 25D again in a country like India, where I was listening to somebody, I think was it yesterday or day before, the Divas conference, in which I know that vitamin D deficiency is rampant in India, and though lower levels of vitamin D are, the relationship in vitamin D levels and osteoporosis is still kind of debated. Definitely very low levels of vitamin D may be associated, in fact, osteomalacia. So definitely a vitamin D. I would get in our population, in the Singaporeans, I always insist on getting a urine calcium corrected for creatinine, because we find idiopathic hypercalciuria quite high in our population because we've got a very high salt content in our diet. So definitely some basic workup for secondary osteoporosis is mandated in this lady. And then the question is, what do we treat her with? Do we treat her? Okay, now she is a 56-year-old woman. She has a T-score of -2 point, how much was it again? -2.6, and she's had a Colles fracture. So a Colles fracture, wrist fracture, you might think, oh, this is just a benign little thing, but a wrist fracture itself carries a risk of having another wrist fracture. The relative risk is about 3.3. And a wrist fracture may also carry a relative risk of a vertebral fracture by about 1.6, and for hip fracture, a relative risk increase of 1.9. So I would definitely treat her. The question is now, what do you treat her with, right? So we definitely rule out secondary conditions. But the question is now, what do you treat her with? She's about 10 years post-menopause, and HRT, I really would not be applied. She doesn't have any other menopausal symptoms, not that you mentioned. And so HRT is a primary treatment for a woman who's more than about 10 years out of menopause. I never do it. Raloxifene, which is a selective estrogen receptor modulator. I'm not sure whether it's available in India. I'm sure it is. That can be used. But remember, the raloxifene doesn't really have hasn't shown non-vertebral fracture risk reduction, but still, she's 56. I would still consider raloxifene in her because it's got excellent vertebral fracture risk reduction. And like I said, a wrist fracture can carry a risk of vertebral fractures too. And just a little pointer to note, raloxifene, I would not recommend in a person who's above the age of about 60 or so, because the Ruth study, which looked at raloxifene, did find this statistically significant difference in raloxifene users of fatal stroke. And this was in the women above the age of 60. So above the age of 60, raloxifene is a no-no, but this lady is considered as a moderate to high risk. So any agent really kind of can be used. The bisphosphonates is also an option in her. And so I think that's how I would approach this lady.
Great.
Manoj, I'm not sure whether you have any comments.
No, it's.
I think you've summarized it very well. My only thing was, in our set of population, like you said, vitamin D deficiency rampant.
Exactly. Yeah.
We look at PTH as one of the investigations.
Markers of, yeah. So I didn't bring that up. So I forgot to say that. I did, kind of, I would also definitely check up, because primary hyperparathyroidism also, and then definitely a vitamin D. I mean, and so calcium corrected for albumin, a PTH, and 25D are all in our list of kind of mandatory kind of investigations to rule out secondary contributors.
Yeah.
Okay. The only other question is, I know assessing bone density at the hip and spine should predict fracture risk in all other sites. But there are some reports in the literature that, you look at a specific site, if you're assessing the risk at the particular site, will that be useful? And also we talked about bone markers. Would we have predicted this Colles fracture if we had done bone markers in this lady retrospectively?
Okay, retrospect. Now, bone turnover markers, now that's a whole different ballpark altogether, okay? The correlation between bone turnover markers and fracture risk is present, yes. Bone turnover markers cannot be used to make a diagnosis of osteoporosis for sure. I would expect that, as Manoj had pointed out earlier, in the first few years after menopause, I mean, these people are rapidly losing bone, so their bone turnover markers are going to be high. So whether I wouldn't personally, I mean, so are you asking, let's say at the age of 50 or 52 or something like that, if we had done bone turnover markers and, could that have predicted future bone loss? Not at that point, because I think you would expect bone turnover markers to be very high anyway in that immediately post-menopausal period. And the other question about what you were asking about, whether a BMD at a particular site can predict fracture risk at that site. Yes, definitely there is a correlation. Obviously, a lumbar spine BMD is going to be the best predictor for lumbar for spine fractures, and a hip BMD is going to be the best predictor for hip fractures. But I never kind of differentiate, and I just look at the lowest T score. Osteoporosis, I like to think of it as a systemic disease rather than, oh, osteopenia here, osteoporosis there, normal here, osteopenia there. I mean, I don't. I just look at the overall picture. But definitely, like I said, wrist fractures, which you think are benign, and you ignore, like I was showing you the osteoporotic career, you know, it all happens because the poor lady, so this 56-year-old lady, you brought her up as a case, so good job. But I mean, most often what happens is that this 56-year-old lady who's had the Colles fracture comes into the A&E, gets her arm fixed or whatever orthopedic surgeons do with radius fractures. I don't know what they do these days. And she goes off and she's forgotten. 2 years later, she comes with a vertebral fracture. Another 5-6 years later, she comes with a hip fracture. So this is where we are going wrong, and this is what we need to correct.
Thank you.
Can I just add something, Bhuma, as a practicing clinician? Now, there's a high chance that this 56-year-old would not have seen anyone in the last 10 years. Okay, I mean, menopause and later. So is there any recommendation? I mean, should we bring them? And I know Professor Chandran was talking about when should we do a DEXA, what, etc. Is there any guidance you can give to us? Should we bring these women back at regular intervals? You know,
you mean after initiating treatment or just hitting menopause?
It's got into menopause at 46.
Okay. Okay. So then we are kind of talking about. Then we are talking about. 1 second. Then we are talking about screening strategies. Let's say that. Am I back?
Yes.
Yeah, sorry about that. So we're talking about screening strategies. Let's step back for a minute. You know, let's assume that this lady came to us before. So the whole question of screening strategies for osteoporosis, I'm not sure whether there are any questions coming up on that, but screening strategies for osteoporosis again kind of differ. You have to kind of decide, you know, in your population, what is a good screening strategy? What's a good screening tool to use? Is it a cost-effective way of screening? That's another important kind of consideration. So in Singapore, what we have decided upon is that any postmenopausal woman, you know, above the age of 50, they get assessed for risk factors. You're not going to say, oh, universal screening with DEXA scan. That's out of the question in countries in the Asian region. I don't think that's a possible option. So any postmenopausal woman, you know, after the age of 50, we are recommending screening for risk factors. And you can use a screening tool like the OST, for instance, osteoporosis self-assessment tool, which just uses age and weight, and it's basically weight minus age times 0.2. And if that person has got a high osteo score, then we send the patient for DEXA scanning. Or the patient is kind of a moderate risk, if the Oster score is between 0 to 20, then what we do is we look for other clinical risk factors other than age and weight, obviously, which is used to assess Oster. We look at, you know, whether there's a family history of fracture, whether she has a sedentary lifestyle, what's her calcium intake, does she smoke, does she drink, does she have any other medical conditions that would put her at risk for osteoporosis? And then if she does have any one of those risk factors, then we send for a DEXA scan. Now, I know that in India, and Manoj could probably elaborate on that, I know that the score has been well validated. The score is another osteoporosis risk assessment tool. The score has been well validated, and the score of more than 6, I think, was taken as your cutoff. So there are all these tools, but definitely, Dr. Jayashree, I would, you know, a woman hits menopause, at least she deserves certain questions from us, even if you're not going to be doing a DEXA scan, which I think is overkill, you know, to do it on every single 50-year-old, assess for clinical risk factors, and then go from there.
Thank you.
Thank you. I'll move on to the next question to Dr. Manoj. A 46-year-old female diagnosed to have polymyositis a year ago has been on tapering dose of prednisone. Started with 60 milligrams per day, and over the past several months has come down to 5 to 10 milligrams per day, depending on symptoms, with occasional high dose during flare-ups. Now, how should we take care of her bone health? When do we start calcium and vitamin D? Do we make assessments for the levels, or we start right away? And if so, how much? And what about bone resorptive therapy, preventive versus treatment? And do you do any assessment, bone density measurement, and decide how you proceed in such a patient?
Okay, so we have a difficult one here. Although using steroids in India is, I think, next to paracetamol or calcium. So we have a problem here, and I think let's understand 2 or 3 things very clearly. If you're going to be dealing with a disorder where the use of steroids, even 5 milligram a day of prednisolone, is likely to be more than 3 months, then this is a high-risk patient. So that's one thing which is very clear. And so we really need to be talking about calcium and vitamin D supplements in this lady. Polymyositis or any of the collagen vascular disorders where the use of steroid is going to be much longer. I think she's at the borderline of 46 years perimenopausal, or as you all were discussing, very touching the menopausal age. I would think of starting her on an anti-resorptive therapy at the earliest. We need to understand that with the use of steroids, actually bone loss occurs very rapidly in the first few weeks. So there's no idea waiting for 6 months or 1 year and then checking the bone density and then deciding about some action. So whether if we can get a bone density done for this high-risk patient, I would definitely get it done. But otherwise, calcium supplement, the required 1000 milligrams diet plus supplement, adequate amount of vitamin D, 1000 to 2000 units a day. One of the bisphosphonates, probably start in this category with an oral bisphosphonate once a week, alendronate, and then follow up clinically at a very regular interval. In terms of menstrual cycle becoming irregular, if we could have a colleague sort of get in and help out, it would be nice. We always have this issue about, do we need to get them onto HRT or menopausal replacement therapy? And unfortunately, at least in my city, 99 or maybe 98 out of 100 gynecologists would say no to hormone replacement.
Okay. Now, another question is, since vertebral fractures can be asymptomatic in these women, do you do an X-ray or a VFA before you think of starting them on bisphosphonates or whatever the treatment modality is?
So, to tell you the truth, probably we would think of prophylactic treatment, but when there is anything to suggest that she's getting some low back pain, getting an X-ray done is really what I think probably even the smallest of institutes or clinics can get a X-ray lateral done of the lumbar spine, and if you could pick up a fracture, it will be nothing like it. Okay.
If it was a younger woman,
but, probably the DEXA is something which we can't do in every center. Sorry.
I think we are losing the audio connection.
Okay. Is that better now?
Between the audio connection. Yeah. My other question is, if it was a younger woman, under 40, how would you assess? Would you still do a bone density? Would you assess the Z-score? Would you decide based on the dose and duration and go ahead with your treatment? How do you approach?
So someone who say less than 40 years, I would prefer that we talk in terms of lifestyle modification with the calcium and vitamin D that I mentioned. There should be some regular weight bearing exercise. As I think Manju mentioned also, this is one of the few disorders where we have medications, but we can't give it lifelong. So we have to think in terms of choosing a patient and looking at the right time to start. Because unlike diabetes or hypertension or cholesterol, where you can give lifelong the medication, this is only for a finite period. So we like to initially start with the calcium, vitamin D exercise part, see that we avoid other secondary factors which can worsen the bone loss, and keep the anti-resorptives for a later date.
Okay. And you brought up exercise, probably muscle strengthening exercises, especially in these patients who have propensity to fall. I think that's something that we have to always think about. Any other point you want to add, Professor Chandran?
Yeah, Manoj, I mean, probably the only other thing is that in my practice, probably not that would influence treatment, given that she's on such a high dose of prednisolone. I mean, she's going to be maintained on, I presume, for a long time, 5-10 milligram per day. But I always either get an X-ray at baseline, or along with the DEXA, I will do a VFA just to at least document the presence of vertebral fractures, silent vertebral fractures. So I would go with what Dr. Boomer was saying, and I would definitely do that. That's the only other probable difference. And then again, because denosumab has been approved for use in GIOP, that's another option which can be considered in such a lady.
Okay. And Dr. Jayashree, would you like to add anything? Because of her irregular periods, would you still like to use HRT as a bone resorptive therapy? I can't hear you.
Yeah, I think it will depend a lot on the pattern of irregularity that we are talking about. If it's an intermenstrual bleeding or a menorrhagia, then I would investigate that. But otherwise, if she's getting 3 to 5 days of bleeding every 50 days or 60 days, I really would not initiate any MHT at that point.
Okay. Okay.
Not for this purpose.
Okay. Dr. Usha, would you like to add anything?
Sorry.
Would you like to add to the discussion?
Well, I think pretty much everything has been said, and it's really important that so many people are on steroids for so many different things, be it asthma or any of these collagen vascular disorders or rheumatoid arthritis, or so many things that this is something that we need to be cognizant of, and at least like Dr. Manoj Chandran has said, make sure that they are calcium, vitamin D status is up to speed, and that's really important. And choosing, because sometimes when they get high dose steroids, they're also at risk for like avascular necrosis. So we've seen that women developing that very frequently, also with high dose steroids, and so I'm a little bit more freer with the prophylactic anti-resorptive, especially if the rheumatologist is telling me this is going to go on for a very long time and not a short-term thing. Also have a dialogue with the rheumatologist about some other disease-modifying agent that they can think of, which and not the steroid is also something that I usually talk with them about.
So can I ask something? So because of the resource constraints in several parts of India, I presume that DEXA scanning is not freely available. So are you folk prophylactically kind of just starting them on an anti-resorptive like bisphosphonate or denosumab or whatever without getting a baseline DEXA scan?
Yeah.
Are you confident enough that, hey, this patient is going to be on it for a long time, she is going to have bone loss, so let's do it, is the approach that's taken, is it?
Yeah.
Okay.
But I can add, Boomer.
Yes.
We are talking about DEXA not being available, but the irony of the situation is DEXA is being done for every woman who's undergoing what we call a preventive health check.
Yeah, same here in Singapore too.
Yeah, but then the people who really need it are not getting it.
Yeah.
So we need to, I think, influence that in some way.
Yeah, 25, 26-year-olds getting health screening DEXA. I mean, for what? I don't know. Yeah.
Right. With respect to getting DEXA, I think initially at least, the bone density could be higher and still the fracture could be higher. I don't, do you think it is, yeah, we would have a baseline. So because we are going to start therapy as early as in less than 3 months on steroids, would we?
So DEXA could be misleading at this stage, and we understand steroids actually, deteriorate the quality of the bone much more. It actually eats up into the bone. So even if you have a normal-looking BMD, I would still think, especially this 45, 46-year-old lady. Someone is 35, 40, I would, wait. I wouldn't rush into the antiresorptives.
But I think doing a DEXA baseline and then using a lower threshold to decide, I think maybe even a better idea.
Yeah. I mean, if you look at the guidelines, I mean, the American College of Rheumatology guidelines are enough to make your head spin. So I usually don't even, I mean, it's very, very confusing. But I would, in my practice, I usually get a DEXA scan and plus or minus an X-ray or a VFA, just to document the presence of vertebral fractures.
Okay, great. Thank you. And now Dr. Vaishali Deshmukh will take over.
Vaishali?
Yeah. Madam, am I audible?
Yes.
Yeah. So I think that was an excellent discussion, and I would like to thank Usha Madam for including me in this privileged expert meeting. And I think I would first congratulate Dr. Manju ma'am. She's taken through the evolution of osteoporosis therapy so crisply, and she's done it in a very small span of time to cover the whole journey of osteoporotic therapy. So I think I'll just start again with the same kind of clinical case scenario. My first question is to, can I have the next slide, please? Yeah. So it's not a question actually, it's a case which is for 47-year-old lady. This is to Madam Jayashree. She presents with oligomenorrhea with the cycles every 3 to 4 months every year and FSH around 72. HRT is recommended in this patient for, say, she has hot flushes or some other reason why she would be needing it. And she reminds the physician that she had a stroke at 26 years of age. There has no established cause been looked into and never been on OCPs in the past, but overall the stroke has recovered. So the question to Dr. Jayashree Madam is, what should the physician do? And should he or she start the HRT, or should he look into it as an absolute contraindication? And what actually, I have actually three parts to this question. First is, what would be the absolute indication for a HRT in such a patient? Second is, what would be the absolute contraindication? And third is, in this situation, what would you think of?
To begin with, the event of this stroke is remote. It's at the age of 26.
That's right.
Right? We need to get more details about it. It's an isolated event.
Mm-hmm.
And no cause has been established does not mean there was no cause. She may not have had OCPs, or she may have had not realizing that they are OCPs. So there are a lot of different ways of looking at it. So we need to go into the history and get little more information on what happened at the age of 26. How was she managed? How was she investigated? But between 26 and 47, she has not had any thromboembolic event at all. She probably has gone through a couple of pregnancies also. We don't know, but she has not had any other incident or episode after that. Bringing her now to the 47 years with oligomenorrhea, with an FSH of 72, has she presented to us with the oligomenorrhea alone, or has she presented to us with symptoms of menopause? So if she
Yeah, she does have these occasional menses. So majorly she has some or the other indication for which she has come to us for HRT.
If she's symptomatic, only oligomenorrhea by itself, I think, does not merit an initiation with the hormone therapy. Exactly. If she has come to us with symptoms, then that is an additional factor. Now, the oligomenorrhea, once 3 to 4 months, I would actually reassure her. She would need a minimum workup, as in terms of bloods and probably just an ultrasound scan. And generally, I like people to induce a period every 60 days. Because just to prevent this hyperplasia and things. So every 60 days, if they do bleed. Now, unlikely that she is going to bleed even with the progestogen if the FSH of 72, even if I give her progestogens every 60 days. So as such, I really don't think that I would push her towards MHT at all at this situation.
Me neither. I wouldn't either. I would be a little leery of that stroke. I mean, even though she does not appear to have had a thromboembolic episode in the last 20 years, I am not sure whether I would be all over her with MHT, with that history.
I think I agree with both of you. What about you, sir?
No, I was going to ask a question to both the ladies. Would you get a BMD done for her?
Yeah, I mean, Manoj, okay, that we'll definitely do that, but MHT therapy, hormone therapy in her, to me personally, I would not run that risk. Definitely, she merits at least a clinical risk factor assessment. But I heard Jayashree ma'am just saying that 46 years is the average age of menopause in India. So, I mean, this is considered pretty much perimenopausal, and that FSH is 72, right? She's menopausal essentially.
So, what would be the absolute contraindications? So, we have a lot of students also attending this meeting. So, can Madam elaborate, Jayashree Madam? Can you elaborate on what are the absolute contraindications for HRT in this population?
Yeah, I think rather than calling it absolute contraindications, we need a little more about her. What is her height, her weight, etc. We need to know her profile a little bit more also. Basically, I would say there is no indication.
Oh, yeah.
So then only we talk about contraindications. And we have to keep this 26 years stroke in mind. We cannot discount it completely.
Madam, what is your take on DVT and thrombotic events caused by OC pills? How commonly do you come across? And you think that's a major hindrance to use of HRT eventually?
See, unfortunately or fortunately, I work in a neuroreferral unit, and we do see people in their 20s being brought in with a neurological event just because they've had one cycle of an OCP.
Wow.
Not uncommon. Cortical vein thrombosis, etc. We are seeing, and that is quite scary. Considering the amount of OCPs that we are prescribing on the one hand, we are seeing women brought in with this. So one is our understanding of this. I think we need to go a little more into it. We probably don't have enough knowledge. But in the same way, it doesn't mean that we should not be prescribing OCPs to women at all. So I would
agree.
Yeah, I would want a little more.
In fact, last week I spoke to Dr. Durusha Madam on menopausal topics, and she said that endocrinologists are very scared to use HRT more than gynecologists. So I wanted your view. We have two endocrinologists also, so we want a view from both the sides. What do you feel, that should we be scared of it?
In this lady, she has not come to us with symptoms, only oligomenorrhea. And oligomenorrhea per se is not an indication for MHT.
But Vaishali, can I just add something? This is actually
yes, ma'am, sure.
No, this is a patient who came to see me since these scenarios were written up by me. This is a patient who came to see me for a second opinion. She is highly educated, very clued into her health kind of person, especially after that event at the age of 26. She said they completely worked her up. Protein C, protein S, Leiden factor, all sorts of things were worked up, and no cause for the stroke was found. But she's always been, that sort of is in the, back of her mind with any health issue. And of course, I think she thought that 47, and actually 46, because for the past year it's been going on like this, that it's a little bit too early for her to undergo menopause. She's been reading that it's 50 or more, and so she went to see someone who said, well, then okay, we'll take you till age 50. We'll take you till the natural age for menopause with HRT was recommended by someone, and then she came for a second opinion on that. And that's when this whole stroke thing was brought up, and I think everyone in this panel will, no one in this panel will touch her with that HRT. Absolutely no, because of that stroke history. And as Jayashree correctly said, cause having not been found does not mean cause is not there. Obviously, something, either an embolic phenomenon or a thrombotic phenomenon or something caused her to have this problem at the age of 26. And therefore, we just have to be extremely, careful and diligent when dealing with somebody like her. But she came mainly for an opinion. She actually came for an opinion about HRT.
So
So,
Usha and sorry.
Yes, Manju.
Usha,
yeah,
as
go
well
ahead.
as Jayashree ma'am, I mean, so since Vaishali was asking about the absolute contraindications, would you consider, I mean, possibly in my mind at least, somebody with a history of a TIA or a stroke, somebody with coronary heart CHT, somebody who has a history of breast cancer, probably wouldn't these few conditions be the absolute, and a history of DVT or pulmonary embolism, wouldn't these be absolute contraindications to starting a patient on hormone therapy?
Yeah. Any
Yes.
estrogen dependent cancer.
Exactly. Yeah.
And anyone who's got a history of some thromboembolic events,
Phenomenon. Exactly.
except in that very rare person, for example, who had an AFib and and that was corrected and they had some event because of that, and that doesn't exist anymore. I'm just saying that very rare thing. These should be or liver disease, active liver disease, and active genitourinary bleeding. All of those things are absolute.
Yeah. And so it's essentially a matter of weighing the risks versus the benefits, right? In this particular lady, I mean, I really can't see a single benefit for starting a hormone replacement therapy when she clearly shows you that, there is a possible absolute contraindication. Even if the stroke wasn't 26 years ago, I mean, I would think I would be very extremely careful in this person to start. And there are, even if when you're, as Manoj was pointing out, I mean, even if she does turn out to have osteoporosis and fractures and all that, there are so many other agents available which can treat the osteoporosis. So the bottom line is that HRT as a treatment for osteoporosis is probably fallen out of favor because we've got a lot of other agents. But in a person who's a younger postmenopausal woman, less than 5-10 years out of menopause, with no contraindication to HRT, and who's having menopausal symptoms, if you can treat her menopausal symptoms at the same time, kind of help her bones, then hormone therapy would be indicated. At least that would be my take on it.
Yeah,
I think this particular lady, we should treat this as an opportunity. She has come to us.
Exactly.
Talk to her about lifestyle changes. Talk to her about what she should expect. We should be happy that she's come to us.
Exactly.
I think she's coming to you, Jayashree.
Oh, thank you.
Did we lose Vaishali?
Vaishali?
Okay, Vaishali, can we go to the next slide, and till Vaishali comes, I'll be Vaishali for a minute. Okay, this is for you. Vaishali is back. Vaishali?
Okay, Manju, I think Usha, you can read the question.
So this is
yes. Hello.
Go ahead. Yeah, please.
Yeah, I'm so sorry I got disconnected.
No, not at all. Please go ahead.
Yeah. So basically, this is a question to Professor Manju, madam. This is a woman with diabetes, and do you think that is it enough for one to substitute diabetes instead of rheumatoid arthritis in the FRAC scoring? Because I think you were very elaborate in mentioning that it's a very good clinical tool for assessment of fracture risk, and maybe OST would be still better in terms of the ease of doing. But how do you look upon FRAX as a score for diabetic patient?
Okay. Vaishali, I mean, I think I'll step back again just a minute, because like you said, there are a lot of students apparently listening in, and, they might not be as clued in as to all this as probably the seniors are. So the first of all, the point to be noted here is that diabetes is a strong risk factor for fractures. Both type 1 as well as type 2 diabetes carry a risk for fractures. And type 2 diabetes is this unusual scenario in which, despite having a higher BMD, the BMD of diabetic patients is higher than normal controls. Despite having a higher BMD, they still are at risk for fractures, and there are numerous pathogenic mechanisms postulated behind it. Now, FRAX, the problem with FRAX in diabetes is that FRAX underestimates fracture risk in diabetes. So what can be used as, how can we kind of use FRAX as an appropriate tool in diabetes? That has been the topic of a lot of debate and research amongst a lot of us. So there are several what we can call proxies. There are several proxies that we can use to attenuate this underestimation of fracture risk in FRAX with diabetes. So one is actually using rheumatoid arthritis as a proxy. Now, if the younger fellows and the students who are listening in, if they go to the FRAX tool, you will see that there are various clinical risk factors listed, and one of them is rheumatoid arthritis. Diabetes is not included as an independent clinical risk factor in FRAX, which is one of the problems with FRAX. Diabetes is indicated as a clinical risk factor in other fracture risk assessment tools like Q fracture, which was actually developed in the UK. It is one of the risk factors, clinical risk factors, which is included in the Garvin risk calculator, which was developed in Australia. So where this whole concept of, hey, can we use rheumatoid arthritis as a proxy for diabetes, came from actually the Q fracture risk assessment tool, in which both rheumatoid arthritis and diabetes were given equal weightage. Okay, so that is where this whole concept of that thing came from. So if you were to go to FRAX, what people are suggesting is that because diabetes is not listed as a clinical risk factor, and if you're doing a FRAX calculation, a person type 2 diabetes, you just stick the rheumatoid arthritis, that box. Okay, so that has been considered as a proxy for diabetes in FRAX. Other proxies have been considered, not proxies, other adjustments, I should say. One is using something called trabecular bone score. And again, for the younger people in the crowd, trabecular bone score is a non-invasive index of microarchitecture. It's a software which you can apply onto the DEXA, on a conventional DEXA, and it kind of gives you a textural analysis. And it's kind of a non-invasive index of microarchitecture. So a low TBS, a low trabecular bone score, means that the bone is degraded. And so trabecular bone score in diabetes is shown to be lower in patients with type 2 diabetes. Though BMD may be higher, trabecular bone score is lower. So that's how people came up with, oh, can trabecular bone score, can it be used to adjust for diabetes? Other adjustments have been considered. Another one is, now we are on this, myself, Ambrish Mittal from Delhi, etc. We are on this diabetes and bone fracture working group of the diabetes and bone working group of the International Osteoporosis Foundation. One of the things that we have suggested is that we take a T-score which is 0.5 standard deviations lower. So let's say, for instance, a type 2 diabetic patient has got a T-score of minus 1.5. This is actually equivalent to a person without diabetes of a T-score of minus 2. So using a T-score adjustment of 0.5. So that could be femoral neck T-score of a difference of 0.5. And then another kind of adjustment which has been considered is increasing the age by about 10 years. So these are all proxies which you can use for a person with type 2 diabetes. Now, which is good, Bill Leslie and his group have looked at the Manitoba registry in Canada, and they kind of looked at which one would be probably the best. It all is because we do not have diabetes yet on the fracture risk on FRAX. So what has been shown is that rheumatoid arthritis seems to be the best proxy, really. It does seem to estimate both major osteoporotic fracture as well as hip fracture risk quite well in type 2 diabetes. TBS, using adjustments for TBS. And again, if the younger folks, if you go to the Google and go to FRAX, the calculator, at the bottom, you will see, once you put in all the stuff, and once you get a major osteoporotic fracture and a hip fracture risk estimation for the next 10 years, there will be a little thing in the bottom that says adjust for TBS. So if you have a TBS value, you can put that in and it'll give you an adjusted FRAX score. TBS is actually adjustment for TBS. What at least Bill Leslie and his group showed was that it seems to adjust better for major osteoporotic fractures. So any of these four can be used with different there are different nuances to it. I would pick rheumatoid arthritis as a proxy because as of now, at least it has shown a pretty good estimation of major osteoporotic fracture as well as hip fracture with diabetes. So TBS also can be used, but how many people have TBS? So that's a question, right?
Ma'am, and how would you assess bone markers? Do you think bone markers are useful in deciding therapy?
Okay. I mean, again, we come back to the topic of bone turnover markers. Again, in Manoj, and you can also chip in whenever you feel like interrupting me if I'm talking too much. But bone turnover markers in diabetes, now that's again another particular situation because type 2 diabetes is actually a low bone turnover state. So you get both decreased markers of bone formation as well as decreased markers of bone resorption, and is a low turnover state, as opposed to Manoj, you were talking about, I mean, right after menopause, I mean, these patients are losing bone very quickly and they're very high bone turnover. And classically, it's increased bone turnover, which is associated with increased fracture risk. But in diabetes, despite having a low bone turnover, despite having a higher BMD, there are risks for fractures. And again, the postulated mechanism behind it is that when you have decreased bone turnover, these things called advanced glycosylation products, AGEs, accumulate, and they kind of interfere with bone material properties, making it more fragile and brittle. So a low bone turnover state in diabetes associates increased fracture risk. But very interestingly, though, I mean, I just came across a paper which was just published, I think, in last month, in which there was no association between bone turnover markers and incident fractures in diabetes. So though, yes, there is an association, there really hasn't been any clear kind of thing to say that you can use bone turnover markers to assess fracture risk in diabetes. So if you're using FRAX, I would stick with rheumatoid arthritis as a proxy. If you have TBS, go with TBS. You could possibly consider using a T-score, which is 0.5 standard deviations lower. So instead of minus 1.5, you'd say that this person has a T-score of -2, or you could increase the age by 10 years.
Yeah. I would like to know from Dr. Chadda sir and even Usha madam and even you as to what bone turnover markers do you all prefer in any patient of osteoporosis, not only diabetes per se?
I think the common anti-resorptive marker that we do is the C-terminal cross collapse, and the bone formation is C1NP. These are the two, one of the resorptive and one of formation, which is useful. As a matter of fact, Vaishali, I think everyone who's hearing us should look up Manju's article on diabetes and bone. It is a review article about 3 years ago.
I saw that, yeah.
So she's sort of more or less covered it in that article. And
so what is your view on urinary calcium create as a resorptive marker, which is very easily available, very easily...
it's not.
There is no such data, and it can't be used as a surrogate.
No.
And very variable, Vaishali. I mean, bone turnover marker is one of the biggest. I'm not sure how it is in India, but assay variability is one of the biggest problems that we face in bone turnover marker measurements anywhere in the world. And urinary bone turnover, I mean, serum bone turnover markers itself carry so much of variability. I mean, they have to be done fasting, they have to be done at the same time of the day, etc., etc. I used to use urinary bone turnover markers. I used to use urinary CTX and all that, but I stopped doing that because, I mean, the variability is even much more. And particularly in diabetes now, you could, there are all these bone turnover markers which are being kind of considered other than P1NP and CTX, osteocalcin, pentosidine, etc. etc. Pentosidine is more a marker of advanced glycosylation, but those are markers which can be considered. But like I said, I just came across this, Nicola Napoli. I mean, if you can look up, I think it was JBMR, I'm not certain, but just last month, they found that they could not find any association between bone turnover markers and incident fractures in diabetes.
What is the absolute indication, madam, for doing bone turnover markers? Which are the conditions where you actually think of doing it?
The one place where I absolutely rely on bone turnover markers, again, I'm not sure if I'm taking over this conversation completely, I'm sorry. But just because you asked, the only place where bone turnover markers are very expensive, that's the other thing, okay? In Singapore too, I mean, I first look at the wallet of the patient really before I order them, because it doesn't really provide me with any further information in the general osteoporotic population other than maybe assessing for compliance. I'd check a baseline and 3 to 4 months later, but I think I have developed enough of a relationship with my patients that if I ask them, are you taking the medicine? Either they are scared or because they trust me, they'll say, if they're not taking it, they'll tell me. But the only place where I absolutely would check bone turnover markers are in my renal patients. My renal transplant patients, especially because I run a renal transplant bone disease clinic, all I'm sitting and doing there is absolute witchcraft because none of us know what to do. So I look at, those patients, I would assess bone turnover markers to get an idea, because I can't do bone biopsy in all of them. So before starting them on an anti-resorptive therapy, I would check bone turnover markers, and the ones that I use are bone-specific alkaline phosphatase, osteocalcin, and PTH, of course. And I kind of literally put them into a cauldron, stir them, and I hope it comes up with something which clearly tells me whether the patient has adynamic bone disease or whether the patient has high turnover bone disease. That's the one situation where I absolutely do bone turnover markers. But others, I really don't.
I think that was answered very well, ma'am. And we move on to the next question. So can I have the next slide, please? Yes, so this is to Dr. Chadda, sir. This is the case of a 27-year-old lady, and she's been told by the GP that she has osteoporosis. And based on the healed DEXA done at her workplace, so the peripheral DEXA, she's thin, she's healthy, with a low BMI, menstrual cycles are regular. What should she be told? And what do you feel? Healed DEXA should be used, or BMD should be assessed in young people, or what is your take on it?
Okay, so Usha has sent a signal. We need to be a little short and brief. So I'm going to answer this in 2 or 3 lines only. Number one, you should not be doing BMD in young people, even if it's a part of health checkup. I think it's a curse because we get so many problems. One, someone sees a BMD which is low, the patient gets scared, and I have colleagues, I'm ashamed to say so, who would put this patient on anti-resorptive therapy. So let's understand that don't do BMD. If they do come with a BMD report, such a patient, she has other reasons for low BMD, and the commonest reason is vitamin D deficiency, osteomalacia. You treat this patient with vitamin D and you will have a miraculous increase in bone density. Probably only place where within 6 months, 10 to 15% rise in BMD. So I would not do anything more than that except lifestyle changes, exercise, vitamin D, and see that she has enough calcium in her diet. I wouldn't recommend a heal. It's an ultrasound analysis that they do and not a DEXA. And it's more of a nuisance value than a useful value.
Okay, sir. Thank you for that practical tip. So I hand over now to our next moderator, Dr. Krishna Swami. Krishna, over to you.
Able to hear me?
Yeah.
Yeah. Ellorukum panivana maalai vanakangal. Good evening, everyone. It just gives such a great pleasure to be a part of this panel. And I've got a coded message from Dr. Usha Sriram saying that we are running a bit behind. So I'll just keep it focused and get this done with. Next slide, please. I think this case is about the genitourinary syndrome of menopause, the GSM. And I'm pretty sure it's a very debilitating and miserable set of symptoms for postmenopausal women. And again, we were talking about rural India and urban India. I don't know how much patients would come forward to tell all these symptoms. And there is a lot of catch here in terms of evaluation, not to miss out any urinary problems or any malignancy. And what are the implications of treating these symptoms, especially with vaginal estrogens and the role of testosterone, dehydroepiandrosterone, and some more latest advances. So I think I'll give this to Dr. Jayashree, and also comments on incontinence in postmenopausal women. Dr. Jayashree, over to you.
Thank you, Swami. I think this is an extremely common scenario that we see in our practice. Women who have been treated, repeatedly for UTIs, they'll have about 10 or 15 urine routine and urine culture sensitivity reports with them. They've been treated every time with antibiotics and then no relief. Somehow they find their way to us. And sure enough, they have severe atrophic vaginitis. This is a woman who will definitely benefit by local vaginal estrogen creams. And we have dramatic improvement in their symptoms. It's very, very important that we actually think or be aware of this as a cause of recurrent UTI. And they definitely benefit, there is no doubt. There is really no need to go out of our way to do a whole lot of tests before we start this. But certain basic things like, I think, an ultrasound, I would definitely do, because we need to know her endometrial thickness, etc. But while she's on treatment, there is no need to follow up and do regular transvaginal scans to look for endometrial thickness. She is a 67-year-old, so any other relevant blood tests, etc., that may be indicated at that point have to be done. Because surprisingly, when these women are going from one person to another for the UTI, somewhere it is forgotten that she is a woman and she may have other diseases also. So I would look at her as a whole, work her up, rather than point any investigation towards the starting or initiation of vaginal estrogens. And often we get this problem about how long we should be using it. There are really no major guidelines on how intensive the treatment should be, or how often we should use it, or how long we should prolong it. So I have just worked out my own formula. I ask them to start using it every day for at least a month or so, and then gradually taper down and maintain at least once a week, in which time we are going to be seeing her at least after 6 weeks to see how she is improving. And many of them stop using it once they get relief, and then they come back to you after about a year and say, I've got the problem again. So it is important. There is no need to be worried about endometrial pathology just because we are using this, though there is a certain degree of absorption, especially once the atrophic vaginitis improves. Then we don't have to be worried so much. But initial phases, when there is a thinning of the vaginal epithelium, there is a risk of estrogen being absorbed, but it is not something that we need to worry about.
Sure.
These women also come to us with urge incontinence. Again, with the same pathology that's happening in the vagina, could happen in the urinary bladder as well, the thinning of the epithelium. And these women come to us with an urge or an urge incontinence or urgency. Again, not necessarily due to a urinary tract infection or a cystitis. So there is a major improvement when we use local estrogens in these women.
Sure. And what is your experience about, say, topical testosterone or dehydroepiandrosterone? Do they have any role in your?
Personally, I have not used it, so I really wouldn't want to comment.
Oh. So Dr. Manoj and Professor Manju Chandran, any thoughts on this?
Absolutely none from me.
Okay.
I was actually going to take down notes, Dr. Jayashree, because it's something which I'm clueless about.
Yeah, and just before we go, finally about this case, the one concern was systemic absorption with all these studies about stroke and DVT. So you are quite confident that in a short-term treatment, it's not a big issue.
No, on the other hand, you have to look at the relief that she's going to get.
Sure.
And between using, either the type of estrogen that we use also, there is not much of a difference.
Right. Okay. So I think if there are no further comments on this, we can move to the next case. Professor Manju Chandran, this is one for you. And again, as a sort of non-specialist osteoporotic endocrinologist, which we all are, a lot of times we ourselves don't know when to start treatment, because again, with the NORA data, a lot of women on the osteopenic range did end up with fractures. So at what T-score would you recommend starting pharmacological treatment? is the question.
Okay, now, Dr. Swami, now again, why do I get all these difficult kind of questions which cannot have short answers? But to put it very succinctly, first of all, it's not that osteopenia carries more risk for fractures and osteoporosis, okay? It's just that there are more people out there with osteopenia. If you look at the numerical, if you look at the numbers, there are more people having osteopenia than osteoporosis, and that is why there'll numerically be more fractures. It's not that osteopenia is more at risk of having fractures and osteoporosis. Now, the question is whether T-score can be used as a threshold for initiation of therapy. Sure, you can. I mean, you can do whatever intervention threshold you want to, but there are several nuances that has to be considered, because the original WHO classification using T-score, densitometric diagnosis of osteoporosis, was just meant for an epidemiological classification. These gurus who came up with this T-score definition of osteoporosis never meant it to be an intervention threshold. But somewhere along the way, T-scores also started becoming, used as intervention thresholds. And to be fair enough, most of the big trials that, with the anti-osteoporosis agents like bisphosphonates, denosumab, IV zoledronic acid, all of them did use T-score as an inclusion criteria. For instance, the FIT trial, which was with alendronate, that used a T-score of minus 1.6 as an inclusion criteria. Denosumab, the Freedom trial, it included women with a T-score between, I think it was minus 2.5 to minus 4. So T-score can be used as an indication to, as a threshold for starting treatment. But as I've again repeatedly said, there is risk factors above and beyond that of BMD which influence fracture risk. So this, let's say this was, and it all depends on what age the woman is, right? A 50-year-old woman who, like Dr. Jayashree said, maybe just gets a DEXA as part of a health screening. She has no clinical risk factors. All she has is a T-score of minus 2.5. This is a very first DEXA. Would I start treatment? No, I would not probably start treatment. I would look at her other clinical risk factors, and maybe her T-score, she's never had a DEXA scan done before. Maybe she never attained peak bone density, maybe, and I think Manoj would be more qualified to talk about peak BMD. You're going to send me that blog post, Manoj. But a T-score of minus 2.5, maybe she's been running around with a T-score for a long time. So there are a lot of nuances to be considered. But in several of the guidelines, a T-score of less than minus 2.5, as well as in Singapore guidelines, a T-score less than minus 2.5 is still considered as an indication to treat. And in the osteopenia thing, what you're talking about, like I said, it's more because there are numerically more people in the osteopenia range rather than people who have osteoporosis, that there are more fractures there. There are agents which have shown good data in preventing fractures even in the osteopenic population. For example, the recent zoledronic acid use, which is given every 18 months or so in the osteopenic population over 6 years, was found to decrease fractures. But would you give zoledronic acid to a woman in her early 50s with a T-score of minus 1.6? You wouldn't, right? So I think you have to kind of incorporate other clinical risk factors into the decision making and not rely completely only on a T-score.
I think Manju has summarized it well. Just 2 points. One is minus 2.5 is the best indicator that we have as of today. Number two, the risk factors are important. And I think the Ian Reed study was looking at ladies 65.
Exactly. It was looking at 65 and older.
To be kept in mind.
Yeah. Dr. Jayashree?
Yeah. I think I am a non-entity where this is concerned.
Okay. We'll just move on to the next question. The next slide. This is to Dr. Manoj Chandran. Again, this is a very difficult area again for non-specialist osteoporotics like us, where you don't know when to start an anti-resorptive versus anabolic, and to a lot of people, it comes down to what they're comfortable with. If they're not used to teriparatide, they'll just go with some oral bisphosphonate. So how do you choose an anti-resorptive versus anabolic, say with someone with a very low T-score in the spine and hip with a previous history of vertebral fracture?
Yeah. The age is also missing. I would love at least to give me the age of this patient.
Let us take it 60, for example.
Okay, so she's far. So this patient is so going from the it's going into the senile phase. So definitely vertebral fracture 3 months ago needs treatment. There's no doubt about it, with or without the BMD figures. So the important thing in osteoporosis is not choosing the right drug, but ensuring that the patient will continue to take the drug for the required period. So whether it's 2 years, 3 years, 5 years, 10 years. So that's most important is the compliance factor that comes into picture, and obviously who's going to pay for it, because in India most patients have to pay from their pocket. So there's no idea, prescribing the best drug for osteoporosis when this patient will not take it for more than a few months. So a simple answer here would be, if someone who's in the late 50s, early 60s, I would think of an anti-resorptive as the first line of therapy. And most guidelines actually say that if the patient tolerates oral bisphosphonate, that should be the first line drug. I somehow have a little bias towards using parenteral drugs in these patients also. So because the compliance definitely improves with an injection which needs to be given once in say 12 or 18 months. If my patient can afford, I do like to use denosumab, because probably the long-term effects, not in the first 2-3 years, but if you look at 5 and 10 years down the line, the results with denosumab are better. I would think of an anabolic therapy only, not with these figures, but if there have been more than one fracture in this lady, 2 if the T-scores were say -4 or worse. But otherwise, I would go with the anti-resorptive in this set of figures.
Sure. Any differing views from Professor Manju Chandran or Dr.
It's
Jaiswal?
not really differing, like Manoj said, in this particular patient, I mean, I would probably, I mean, anything goes really. I mean, I really don't do the first line, second line kind of therapy any longer. But in this particular patient, any of the anti-resorptives which Manoj mentioned, I mean, either oral bisphosphonates or IV zoledronic acid or denosumab are going to be equally effective. The one place where I would definitely prefer an anabolic therapy first is based on this data that I showed you in my talk, in which the patient had very high fracture risk. And this is a very new concept which is now emerging, in which the very high fracture risk are patients with multiple prevalent fractures, patients who had a fracture, the major osteoporotic fracture, vertebra or humerus or a hip fracture in the last 1 to 2 years, and patients with very low T-scores, less than -3, -3.5. That's a very arbitrary kind of thing. But in those patients, the data is now clearly showing that an anabolic therapy would be preferred. Of course, I mean, in countries like India and even in Singapore, anabolic therapies are not cheap. So that has to be taken into consideration. But if the patient is at very high risk for fracture or at imminent risk for fracture, having had a fracture just recently in the last 1-2 years, I would go with an anabolic therapy.
Thank you. Dr. Jaiswal?
My only comment here is that as gynecologists, I think the treatment seems to stop with calcium, vitamin D, and bisphosphonates.
Oh.
So, but if, the need for some kind of a combined care, I think, comes out from the discussion that we've just had.
Definitely, definitely.
Get more benefit and get the optimum management.
And
we need a combined care.
And the problem is that there is data now showing that, this classic way of, a prior use of an anti-resorptive, that the classic traditional method that we've been using, first use an anti-resorptive, and then when all else fails, go to an anabolic agent. In fact, that can actually do more harm to the patient, because the sequential treatment of an anti-resorptive first, followed by an anabolic therapy later, can actually has been shown to cause a decrease in BMD at the spine and the hip, which kind of recovers after about 18 months. But in somebody who's at very high risk of fracture, who's just had a fracture, she's going to be at very high risk of fracture in the next 18 months or so. And if you then do follow that sequence, you're actually doing the person a disservice. That's something to be considered. Anabolic therapy has its place as a quote unquote first line therapy in some situations.
Yeah, I think with the denosumab teriparatide combination right from the beginning, if someone is going to pay for it,
Yeah,
there's
a combination
good data
therapy would be the best. Yeah, the treatment naive patient just start on both denosumab and teriparatide together. That has shown good, at least BMD data. We don't have fracture data, but that has shown good BMD data.
Excellent take-home message from both of you. I think that's very, very important.
Thank you. So it's very clear that there's a lot more to discuss, but we got some really useful pointers this session. So for want of time, I'm just giving it back to my co-moderators. Thank you.
I think we should move to the Dr. Mangaleshwari for the takeaways. So we're running a bit behind. If we have time, we'll come back to some questions. So Mangaleshwari will now do the takeaways, and then I'm sure during the audience Q&A, a lot more of this stuff is going to come up. Even I already have a bunch on my phone, a bunch of questions. So,
hello, ma'am. Am I audible to you?
Yes, Mangaleshwari.
Okay, I will share screen now. Before that, good evening, everyone, and thank you to Professor Manju Chandran and Professor Manoj Chandran and Dr. Jayashree Gajraj for the wonderful presentation and discussion on osteoporosis and menopause. And thank you to the moderators for excellent question and answer session and case discussion. Finally, I'm very grateful to my mentor, Dr. Usha Sriram, for giving me the opportunity to do the takeaways. Thank you, ma'am. Just start the takeaways now. Is my screen visible, ma'am? Right.
It is.
Okay. Right. The keynote address by Professor Manju Chandran, it's been quite challenging to do takeaways because she has taken a whole journey of osteoporosis in a shorter period of time. So I will try and do few of the keynote. The mantra to monoclonal antibodies is the osteoporosis treatment from mantra to monoclonal antibodies. And half of the few fractures had prior other fractures, and whose job to help. So there are screening for osteoporosis, and there are several simple questionnaires to FRAC score, and osteoporosis self-assessment tools are available to do the screening for osteoporosis. And both FRACs and WOSATA are validated, and actually FRACs is internationally validated in multiple cohort study. India actually uses a Singaporean Indian FRAC score. And the diagnosis of osteoporosis depends on so many things, including the body composition analysis and 3D reconstruction, TBA and DEXA. And we need to really look into secondary osteoporosis as well. So several medical conditions can cause osteoporosis, and 75% of the postmenopausal osteoporosis may have secondary contributor as well. So we need to rule out before the treatment. And who to treat? So treat patients who are at high risk, who had a trivial fracture, and we need to measure bone mineral density. So intervention threshold is various indications and vary from country specific and age specific as well. The FRAC score meant to be a platform to enable to make decision about osteoporosis treatment. So ideal threshold for treatment should be fixed or hybrid is very unclear. The prevention of osteoporosis is exercise, and supplemental of calcium and vitamin D is intermingled. The advances in osteoporosis medications from estrogens to bisphosphonates to zoledronic acid, and actually in these trials, bisphosphonate is tried and tested, and denosumab is a freedom trial which shows a good evidence of treating the osteoporosis. And regarding bisphosphonate, there are a lot of controversials happening. We need to have a drug holiday. How long do we need to treat? So there are a risk of, osteomyelitis of jaw, and there are rebound risk if you stop and restart the drug. The risk-benefit ratio favors bisphosphonate in women at things. So the anabolic teriparatide is also useful only when they have high risk of multiple fracture. So advances in treatment move from the older pharmacology to targeted therapy. And in frame study, romosozumab is quite effective. Patient at very high risk of second fracture usually occurs in the first 2 years. So you have to think about anabolic agents, and you need to really look into various other risk factors along with that. So the conclusion from Professor Chandran, so there are good ways to predict who might to get a treatment, and the current treatment is designed for broad epidemiology. So osteoporosis management curve she mentioned, and haven't actually written here. So the question one about menopause, the age of menopause, whether it's changing in our country. Yes, menopausal ages in India is 46 according to Pan India study, and Foxy it says 47.5 years. So we need to actually create awareness, and more from urban people requested came for help. So, but we need to ask leading questions about hot flashes, mood swings. So vasomotor symptoms are quite significant cause for help. So we need to really assess the classical symptoms, but we don't need to do any SSH for this one. And duration of menopausal symptoms, it is quite variable. As Dr. Jayshree Gajraj said, she has hot flashes for 10 years. So we have to actually reassure, and perimenopausal time, we have to have a time to intervene about osteoporosis risk assessment. The case one is the low impact fracture in young postmenopausal women. How do you manage? So the question is 56-year-old female with the menopause at the age of 46, and she had a Colles fracture. So whether you treat the patient, yes, but we need to rule out the secondary causes as well, like the blood tests like thyroid function test, creatinine, CBC, ESR, vitamin D, etc. But there is no particular Z-score threshold, but low Z-score threshold indicates other causes as well. So we need to look for increased risk of other fractures. So treatment with relaxin, but we should not actually do it above the age of 16. So bisphosphonates is another choice of treatment as well. The post-menopausal woman, we also need to screen for risk factor. OSTA score in Singapore, and they commonly do it. The number 2 question is polymyositis, the patient who is on long-term steroids. How do you proceed? So patients who are on long-term steroids, they are at high risk of developing osteoporosis. So what we need to do is we have to give them calcium and vitamin supplementation. Do we need to do a DEXA? Of course, yes, but we don't know when. And bisphosphonate probably is the first choice of medication, but we need to follow them clinically. They are at risk of fracture. So if symptoms, then we have to do a X-ray. So for younger patients less than 40 or around 40, we have to encourage them to do weight-bearing exercise, lifestyle modification, again calcium and vitamin D, probably anti-receptive medications like we have to give it at the later stage. And patients who are at irregular cycles, we have to investigate further, but we need to do more history. And case number 2, HRT in perimenopausal, would you recommend? So the patient, 47-year-old female with the oligomenorrhea, with a FSH of 72, had a history of stroke, so CVA. So whether we give HRT to them is no. And the absolute answer is no, because it is the absolute contraindication to give HRT to a patient who has got a history of stroke. And as Dr. Jayshree Gajraj mentioned, even the thromboembolic events occur with one cycle of OCP. Probably the patient might have forgotten. So we have to really look into that. But definitely HRT is no in this case. Question number 3 about FRAX scoring. So can diabetes be substitute for rheumatoid arthritis? The answer is yes, because diabetes itself is a strong risk factor for fracture, both type 1 and type 2, even though it has got a higher BMD in type 2. So FRAX actually underestimate the risk of osteoporosis, fracture risk in diabetes, and Q fracture risk can be used in diabetes, and trabecular bone score is more useful than the along with the FRAX scoring. So they were debating about bone turnover markers, which Professor Chandran said that it's quite expensive and variable. We have to take it in the daytime at the same time, etc., etc. And case number 3 about screening of osteoporosis in young women. Professor Manju Chandran said straight away, no, we don't do BMD in young people. If at all patient comes, then we have to check vitamin D and treat accordingly, like lifestyle management. Here DEXA is ultrasound, but it's actually not useful. It's like a community screening. So it's not a definite test that gives us whether it has osteoporosis or not. Case number 4, about atrophic vaginitis. So always keep in mind, if any postmenopausal patient comes with recurrent UTI, think about atrophic vaginitis, and the treatment is local estrogen cream, and there is no evidence or no significant risk of endometrial hyperplasia if you use it for short term. And there is no guidelines on duration of treatment, but as Dr. Jayashree Gajra said, she normally gives them daily for a month and then taper it off once a week and then review to see how she is. So because it is small amount is absorbed into the bloodstream, the risk of endometrial hyperplasia is almost nil. The question number 5 about treatment of osteoporosis. At what T-score we have to do the intervention? And Professor Chandran mentioned about it. It's quite tricky question, and it depends on the age and the risk factor, and they normally do it less than -2.6 in Singapore. The FIT trial also mentioned about -2.6 and Freedom trial between -2.5 to 4. So the NORA data mentioned about more people develop or get fracture in the osteopenic state. Professor Chandran mentioned that because there are more people with osteopenia than osteoporosis, sense more fracture. So there's no clear evidence about that. So question number 6 about anti-resorptive versus anabolic for osteoporosis. When to give anti-resorptive and when to give anabolic. If the first line is bisphosphonate, it all depends on the age and adherence, the compliance with the patient. So you have to choose the right drug. Oral bisphosphonate is the first choice, which was mentioned by Professor Manju Chandran, and denosumab if the patient is able to afford. But if the patient has got a very high risk fracture risk, then we have to go for anabolic therapy. That's all I think. Thank you very much.
Thank you so much. I think we go straight to Vidya. Before Manju, I think it's way past your bedtime.
Oh, no, it's okay. It's okay, Usha. I'm fine. I'm fine. Thank you.
Thank you, Usha ma'am, for inviting me to be part of this session. So it's going to be rapid fire round. I'm just going to ask like 5 questions. There are some questions, just clarification. So what may be the reason for vitamin D deficiency in a sunlight abundant country like India? So do the reference range for vitamin D needs to be changed for the Indian population? So this is a question to the panel.
If I could take that question, I think a couple of factors that come into play. One is we don't go out in the sun when we should be, that is between 10 a.m. and 3 p.m. Secondly, when we do go out, we are fully clothed. So there's no way that sunlight is going to fall on our skin. Third is the color of the skin doesn't allow for too much of UV light to penetrate. And one of the major factors in urban areas is the pollution level. This pollution cuts off the UVB light reaching the skin. So there could be other smaller things, but I think these are the 4 important reasons.
Okay. Thank you, doctor. Second question is, what would be the dietary source of calcium for somebody who's a vegan?
Is that just anybody can take it? I'm not a dietitian, but again, an Indian food. So but probably green leafy vegetables are good sources of calcium, though obviously there are like these phytates which can interfere with calcium metabolism. Dal is a good source of calcium. Nuts, like almonds and all that can be great sources of calcium. A vegan, I presume, are they okay with soy milk? I mean, I can never keep track of these new age kind of dietary restrictions, but soy milk, fortified soy milk is a fantastic source of calcium.
So,
Manoj, I mean, the Indian diet, I mean.
Yeah, I wanted to ask you, why did you should have started with the milk.
Yogurt, yogurt, milk,
yogurt,
I mean,
cheese.
so yeah, yogurt, milk, paneer, these are all good sources of, I kind of assume that there's dairy also, some people are, kind of have their objections to, but so pure vegan, dairy is the best source, I would say that dairy is the best source of easily absorbable and bioavailable calcium. Cow's milk, buffalo milk, whatever, any of those.
Absolutely.
And also the quantity, because like 3 cups of milk, it's like 8 cups of greens, and 3-4 cups of dals and lentils. So absolutely nothing. If you can get dairy in a small portion, you can get much more than the large portions that you have to have of the other foods. So and some of the milk that is coming out now, I think some of the ones that come in Tetra packs are actually also fortified in vitamin D.
Okay, yeah. The other thing is that in Singapore, I mean, a lot of Asians, I personally have lactose intolerance, and so I can't handle any dairy products. But so in those people with lactose intolerance, and soy milk and all that are great alternatives. But dairy is probably the best source.
I presume vegan diet does not include dairy products as well, and I think they should depend on.
See, Manoj, I told you. I mean, I knew that there was this.
Vegans cannot have dairy products. They can try almond milk, soy milk.
Vidya, I had a suggestion. If we can stop the screen sharing, at least we can see each other.
Sorry, sir, I didn't get you.
If you could stop the screen sharing, then probably we'll be able to see each other and,
Oh, okay. I have not shared my screen.
Yeah. So we can see you also better now.
I can see me as well. Okay, fine. So the next question is, what about the combination of calcium and vitamin D in the drugs? There are several combinations available in the market. So what would be the right combination, and do they work better together?
So probably calcium, the bioavailable being equivalent to about 500 milligram is the most popular brand. What is variable in these brands is the vitamin D, which ranges from 200 units to about 2000 units now. So anything which gives you 1000 units plus would be good. What is an absolute no is what is available probably only in India is calcium with activated D3.
Exactly.
And which is a favorite with the orthopedic surgeons, unfortunately. So we should go with calcium with up to 1000 units of vitamin D, which would be very good. And as a combination, probably you are improving the absorption of calcium and taking care of the vitamin D deficiency at the same time. And Indian data talks about between 70 to 90% vitamin D deficiency. So you have to take care of that. Until I think the only 2 or 3 states in India, that's in North India, where milk and oil is getting fortified. Otherwise, we are all dependent on supplements for vitamin D.
Thank you, doctor. So the next question is loading dose of vitamin D, that is 60,000 units once a week for 6 weeks recommended by the National Osteoporosis Society, is that associated with false? Because we do see patients given intramuscular injections of vitamin D and also the loading dose. Is there evidence to suggest that's associated with false?
May I take that question?
Yes.
Yeah, so that's actually, I mean, I don't know whether this is evolving rapidly into a calcium vitamin D kind of story, but yes, so there is, vitamin D carries with it a lot of baggage too. So somebody with vitamin D deficiency, a loading dose, 50,000 units once a week for 6 to 8 weeks, followed by maintenance is what all of us recommend. In large bolus doses of vitamin D definitely has been associated with increased risk of falls and fractures. And there's also this what we call a reverse J-shaped curve with cardiovascular mortality. So these things should be kept in consideration. And I was told that, again, there are doctors in India who are giving these humongous doses of vitamin D, 500,000 IU and all that with impunity. And that's definitely a no-go. So I'm glad that somebody brought it up.
So I think we touched upon this topic, the role of concomitant use of agents like HRT and anti-resorptive agents together. When would we use these agents? Where is it exactly indicated when we'll have to use 2 agents at the same time?
Manoj, okay, this brings us to the combination and sequential therapy. Combination therapy, yes. I mean, there is no fracture data, okay, in any of these combination therapies. There is no fracture data at all. HRT and another anti-resorptive, there might be a slight BMD increase, but I do not see any indication for a combination of HRT and bisphosphonates. I never do it, actually. So there is BMD data, but I don't see any reason to do that.
Yeah, I agree on that. I think with the experience that we've got with the bisphosphonates and now with denosumab, combining it with HRT is really not going to add, except for the risk factors that we anyway keep worrying about.
Exactly, yeah.
So the next question, I think they just needed clarification. Young patient on steroids, should bisphosphonate treatment be based on DEXA or empirical steroids given as long as we are preventing empirical bisphosphonate to be given to prevent osteoporosis as long as the steroids are given for the duration of the steroids?
Yeah,
So,
can I
Manju?
just answer?
Yes, Dr.
Yeah, okay.
And then the thing is, because when Manju had asked me the question, if DEXA is not available, would you still consider using bisphosphonate? So in a young patient, let's say in premenopausal, and let's just take under 40 or something, definitely the first concern is if there is, reproduction, if they're considering pregnancy. So I would definitely stay away from bisphosphonate or any of the osteoporosis therapy. Just go with calcium, vitamin D, fall prevention, all of those things, because they are premenopausal. But otherwise, we have to risk stratify them in some way, whether it's BMD or whether it's using a FRAC score or something, and risk stratify. And obviously, as Manoj and Manju has said, if they are low risk, you don't want to do anything other than calcium and vitamin, meaning that they have not fractured anything already. If they're if we don't know their if we know their BMD and if it's okay, we don't have to do anything. We just have to make sure that their calcium, vitamin D are fine. But if they are moderate or high risk, based on any of this, and if they're on going to be on steroids for more than 3 months, I'm just saying that I would consider
An anti-resorptive.
So I just want to now give it to the experts.
Yeah, no, I agree. I mean, again, GIOP is a whole different class altogether. And there are lots of people who consider just GIOP as very high, fracture risk. And, they get started on therapy. But if I know that the patient is going to be on steroids for a short term, I might still hold off.
Yeah.
But we, at least in Singapore, obviously DEXA scanning is easily available. So DEXA is a must on all patients who are starting on long-term steroid therapy and who you anticipate is going to be on steroids for a long time. Then baseline DEXA is a must.
Okay, so this one question.
Just add one question, one comment, Vidya. I think MHT per se is not indicated for primary prevention of osteoporosis.
Absolutely.
That's a message that we need to give.
You have lots of other agents available now.
So there's one question on menopause. How effective is sulfasalazine combination with alfuzosin combination in treating urge incontinence without UTI in elderly post-menopausal women?
Once we have done an adequate workup as in a urodynamic study and to find out whether there is a combination of stress or urge and stress, yes, sulfasalazine is useful. But when there is a definite mechanical reason, as in a descent, etc., then surgery is indicated to take care of that.
Thank you, Doctor. It's been a wonderful session. I think we are at the end of the question answer session as well. And I think we have covered a significant portion of this osteoporosis topic. And I do not have any more questions to ask. I'm representing the attendees.
This has been just absolutely amazing. Thank you, Manju, for spending so much time. And I know it's getting late in Singapore.
No problem at all.
And your keynote address was really, I think, fabulous in just taking us through that whole journey and a little peek into what's coming. The moderators have been amazing. Thanks, Bhuma. Thank you, Vaishali. Thank you, Swami. And Jayashree and Manoj, I cannot thank you enough for always being there and whatever we do and coming and just hitting it out of the park, as they say. Thank you so much to all of you. And this is the valedictory function. So thank you all for staying for the valedictory function of the Divas virtual series. We want to thank everyone, all the keynote speakers, the Meet the Professor speakers, the moderators, the takeaway coordinators, the Q&A coordinators, our sponsors. Fortunately, the webinar, the format is cost way less than the other conferences that we have been doing in the past. Maybe this is the way it should be in the future, but still you need a little bit of help and our sponsors. But more importantly, what they've done is, spread the message of these programs to the doctors in their databases. And so they have logged on and learned so much. Thank you so much. We used Dr. Hardik's, event management team from Ahmedabad. I have to tell you, anyone who is considering using an event management team, please give Dr. Hardik a call. It's been one of the nicest things, to work with the whole team. And of course, I would be remiss if I do not talk about my own team at Divas, who literally do, I'm just the face of it. They literally do everything. And I thank them all really from the bottom of my heart. Thank you so much and have a great night. Thank you.
Thank you so much, Usha. Thank you all. Manoj, Jayashree, lovely to meet you virtually, and all the moderators. It was a superb session. Thank you so much.
Thank you.
Thank you.
Reach Usha.
Thank you, madam.
Thank you so much.
Yeah.
Thank you so much.
Congratulations, madam.
All the work starts tomorrow. Thank you so much.
You deserve
Okay.
a break, Usha. Okay, good night, everybody. Bye-bye.
Good night.
Good night. Bye.
Bye-bye.